So the first question, like as we discussed, malignant hyperthermia is common with among local anesthetics, succinyl choline, propofol, barbiturates. Many of you correctly answered. It is succinyl choline, and you see this. The clinical features, please note down, very, very, very important. As you rightly told, it's not only hyperthermia. Before diagnosing it's a malignant hyperthermia. Before that, you see the temperature. You can see. Very good. Masseter spasm. Please write down masseter spasm and muscle rigidity. Masseter spasm, muscle rigidity, and cardiovascularly it may cause tachycardia, hypotension, arrhythmias, and cardiovascular collapse. Cardiovascular collapse. And on respiratory system, it causes tachypnea and cyanosis. These patients has dark urine, hyperkalemia, and acidosis, both metabolic and respiratory acidosis. Metabolic and respiratory acidosis. And unexplained desaturation. So how does this question come? All of the following are the features of clinical features of malignant hyperthermia except. So you have to know what happens to the muscle, masseter and muscle rigidity, what happens to the cardiovascular system, tachycardia, hypotension, arrhythmias, cardiovascular collapse, and respiratory tachypnea, cyanosis, unexplained desaturation, muscles, dark urine, and metabolic component, metabolic and respiratory acidosis and dark urine. Now tell me, as you rightly answered, what is the most common drug which causes malignant hyperthermia? Succinyl choline. Very, 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 very important. Succinyl choline. And followed by the other agents, other probably inhalational agents like methoxyflurane, enflurane, halothane. These are all the various inhalational agents. Trilene, lignocaine, and ketamine. What are the drugs that can safely be used? Non-depolarizing muscle relaxants, barbiturate drugs, barbiturates like thiopentone and methotrexate, which we will discuss, benzodiazepines. Any benzodiazepines you know? Very good. Midazolam, propofol, nitrous oxide, opioids. Okay, these are the drugs which can safely be used in malignant hyperthermia. Any doubt? Yeah. We have to ask like any previous exposure to any anesthesia where they had a complications. So that is how we will ask the questions. Particularly if you see even in India, few groups, particularly if you take in Andhra Pradesh and Telangana, there's a group called Vaishyas, like where they are more common, who will be having that. So based on that, we'll take the family history or any of their family members during the anesthetic exposure, they had a complication. That is how we'll ask. Okay. And now, based on the clinical features, suppose the patient had a malignant hyperthermia intraoperatively, how do you manage that? How do you manage that? It's simply discontinue volatile anesthetics and succinyl choline. Whichever is causing that, you stop that. Discontinue that. And change the anesthetic tubing and soda lime. As we discussed, anesthetic tubing and soda lime has to be changed because that keeps in the closed circuit, it's keep going on. And what is the drug of choice? Fantastic. Dantrolene sodium. Drug of choice is dantrolene sodium, which is given up 2.5 milligrams per kg IV. And you can repeat up to maximum of 10 milligrams per kg. And intraoperatively, how to do invasive blood pressure monitoring, ECG, ETCO2, that is end-tidal carbon dioxide, temperature, all these things has to be measured. And we will discuss about capnography in detail, but remember, when there is this is a normal capnography waveform. And if there's a rapid increase in EtCO2 like this indicates this has rapid increase in EtCO2, which is seen in malignant hyperthermia. Very, 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 very important. We'll discuss in capnography. There will be 12 waveforms of capnography. You remember the 12 waveforms. I can give it in writing that 1 mark in your July 28th examination will be there from that. Okay, capnography. Capnography is nothing but the measure of carbon dioxide over time. What is meant by capno? Carbon dioxide measure over time. How does it happen? So we'll discuss about this. Then because the patient is having temperature, you do cooling measures like lavage, cooling blanket, cold IV solutions. Acidosis, because the patient has metabolic acidosis and respiratory acidosis both. For metabolic acidosis, you treat with sodium bicarbonate, and respiratory acidosis, you hyperventilate. This is for respiratory acidosis. And this is for metabolic acidosis. Then coming to cardiac instability, the patient you give inotropes and antiarrhythmic agents. Then if the patient has hyperkalemia, what is the treatment? Fantastic, IV calcium gluconate, which has membrane stabilizing property. Very good. Then dextrose insulin solutions. Very good. Very good. Potassium binding resins. Very good. Nebulizations, salbutamol nebulizations. And if nothing is working out in this, then what do you do? Fantastic, dialysis. What's your name? Sushruth. Both of you coming there. Come. Give them a big round of applause. Come fast. Come fast. Both of you. Half off. Okay. So write out hyperkalemia, IV calcium gluconate, dextrose insulin solutions, salbutamol nebulization, potassium binders or resins, and dialysis. Okay, this is about malignant hyperthermia. One, if I ask you to pick up few points about malignant hyperthermia, it is autosomal dominant, chromosome 19, defect in the ranitidine receptor, pre-hyperthermic diagnosis. What are the pre-hyperthermic diagnosis? Very good. It is increased EtCO2 and mesospasm. Then diagnosis, then clinical features like mesospasm, muscle rigidity, tachycardia, hypotension, arrhythmias, cardiovascular collapse, tachypnea, cyanosis, dark urine, hyperkalemia, metabolic and respiratory acidosis, unexplained desaturation. Drugs triggering is very, very important. Succinylcholine, methoxyfurine, enflurane, halothane, trilene, lignocaine, ketamine. Drugs safe, non-depolarizing muscle laxants, barbiturates, benzodiazepines, propofol, nitrous oxide, opioids. And the particular reason why I explained all the malignant hyperthermia protocol rather than just saying you give dantrolene is you'll get a questions usually all of the following are the treatment modalities of malignant hyperthermia except so you have to understand like what exactly you noted that. Understood? So you have to take the cooling measures and you have to change the anesthetic tubing and soda lime. This is also very important. It's not that you can't forget that you can change that. Then what are the monitoring you do and how you address hyperkalemia and metabolic and respiratory acidosis. Then, as I told, another important thing here itself we'll discuss is, please note, as you already noted down, it's fine. For IV cannulas, this is your competency code. A is 9.1 S based on skill, 14 gauge. Come on, keep saying 14 gauge, 16 gauge, 18 gauge, 20 gauge, pink, 22, blue, 24, yellow, 26, purple or violet. What is the maximum flow rate in ml? 270, 180, 90, 60, 45, 24, 12. What is the most common cannula used in polytrauma? If at all available, it is 14 gauge, and if not in the options, if 14 is not there, then go for 16. 14 gauge or 16 gauge. Cannula used in neonates? Very good. 24 or 26 gauge. Okay. I can say it confidently, this competency code of AS 9.1S is going to fetch you 1 mark for sure in your examination, because going to see the trend, like who is preparing your paper, who is the designated authority to connect your paper? AIMS. If you see, the AIMS is what, like conducts INSET examination also. Yes or no? Institute of National Importance Common Entrance Test. And if you see the trend of the last 6 papers, 4 times this question was there on IV cannulas. It was such an important thing. And this is what one of the basics that you are doing it day on day, right? Yes or no? Knowing about the IV cannulas, whatever the competency codes, the questions which you expect in this mock examination and the future is where you will be having very relevance to your practice and like how they're going to do that. And one question from basic life support will be there for sure. Okay. So this IV cannulas you should not miss. Then we'll come to our next question. Hypotension is caused by all except halothane, propofol, ketamine, thiopentone. So in this, halothane is an inhalation agent, propofol, ketamine, thiopentone are IV induction agents. What do you have to understand is, we have to, I told you balanced anesthesia is a combination of amnesia, analgesia, and muscle relaxation. Again, if you see this, again, in the very first thing, with this competency code AS 1.1K, we discussed what is the triad of balanced anesthesia, amnesia, analgesia, and muscle relaxation. Very good. When you say amnesia, analgesia, and muscle relaxation, here in this, for analgesic, for your understanding, for analgesia, intravenously you give through what drugs? Very good, opioids. Inhalationally, you give it through nitrous oxide. For muscle relaxation, you give through muscle relaxants like depolarizing or non-depolarizing, either depolarizing muscle relaxants or non-depolarizing muscle relaxants. And amnesia, for amnesia, sedation, and hypnosis, for these components, intravenously, you can give through few agents like thiopentone, propofol, ketamine, and etomidate. Inhalationally, you can give through halothane, isoflurane. This is inhalationally, isoflurane, sevoflurane, desflurane. So that is, what do you mean by induction agents which take care of amnesia? The patient, the drugs which you use for this thiopentone, propofol, ketamine, etomidate, those drugs, by giving the drug being administered intravenously, they take care of this amnestic component, sedation, and hypnosis part. Okay, inhalation. Now we'll discuss the most important points about these drugs. We'll go to page number 66. Go to page number 66, 65. See here. So the IV induction agents, intravenous induction agent 65, if you see this, this is the NMC Competency Code, AS 4.1, where knowledge component will be assessed, where it is vertically integrated with your pharmacology. Again, this is a very important concept, where based on the structure, these IV induction agents have been classified into barbiturates and non-barbiturates. Barbiturates are thiopentone and methotrexate. Non-barbiturates are propofol, ketamine, etomidate, and benzodiazepines. What is the, where do they go and act? Based on the receptors. All the agents what we discussed, barbiturates and benzodiazepines, all they go and act on the GABA receptors, except ketamine, which acts on the NMDA receptors. Now you tell me, both barbiturates and benzodiazepines acts on which channel? Chloride channels and on GABA. Yes. So which one increases the duration and another increases the frequency? Which increases the duration and which increases the frequency? Barbiturates increase the duration. Benzodiazepines frequency. How do you remember this? See, we'll in the examination again we'll be confused, right? How can you remember? So what is the unit of frequency? Hertz. So benzodiazepines BZD, its unit is, it assesses the frequency, and the unit of frequency is hertz, Z. Z is there in both. So you remember one thing. Obviously, the opposite will be you can remember. Yes or no? So barbiturates increase the duration of channel opening. Barbiturates increase the duration, and benzodiazepines increase the frequency. Okay. Then for this entire chapter, for this NMC competency code of ACE 4.1, if I want to consolidate in a single table, it comes from the next page. So thiopentone, propofol, ketamine, etomidate. Yes, I don't. Thiopentone was discovered in 1934. Propofol in 1977. Etomidate in 1972. And ketamine in 1966. Mechanism of action, all of this acts on thiopentone, propofol, etomidate, they acts on GABA. Ketamine acts on NMDA receptors. Physical form, thiopentone comes in yellow powder form, which when it anything, suppose your antibiotic also, if it comes in a powdery form, when you want to give the drug, what do? You reconstitute and mix it. Okay. But these other things are, they come as milky white liquid or colorless milky white liquid. It is clear or milky white, clear liquid. What is pH? Very, very, very important. The pH, it is 10.7 here. Thiopentone, which is highly alkaline, very important point. Highly alkaline. And for propofol, it is 7 restol, nothing much to important. Then coming to induction dose in milligrams per kg, you need 2.5 milligrams per kg of thiopentone, propofol 1 to 2, ketamine, etomidate 0.2 to 0.4, ketamine 0.5 to 2. So when you are given the drug, the patient has to be induced. That means the patient has to be anesthetized. Yes or no? How will you know the drug, whatever drug you have given, like thiopentone, propofol, it started acting? You have given the drug. You should know, right? Like the patient is really anesthetized or not. That is called as first sign of induction. For thiopentone, the first sign of induction is loss of eyelash reflex. Loss of eyelash reflex. And with propofol, it is loss of response to verbal commands. Loss of response to verbal commands. And within how much time the action starts? The onset of action starts with thiopentone 15 seconds and propofol 15 seconds. Etomidate 30 seconds, ketamine 30 seconds. That means this is called as also called as one arm brain circulation time. That means the amount of time, by the time you give the drug in the hand, it goes and acts on the brain. One arm to brain circulation time is 15 seconds. And duration of action, once you're given, how much time it acts? It is 10 to 15 minutes, 25 to 30 minutes for propofol, 25 to 30 minutes for etomidate, 35 to 45 minutes with ketamine. Half-life, it is 10.4 hours for thiopentone, 2 to 3 hours for propofol and ketamine, and etomidate, and 3 to 4 hours for ketamine. So once you complete this, we'll go to the next page. Because what are the various actions? Noted everyone? Yes. Then coming to what is its metabolism? Here it is almost in the liver. Here 80% in the liver and propofol 80% liver, 20% extrahepatic. What is action on CNS? CNS, it is cerebroprotective, very important. Cerebroprotective. So you can comfortably give this thiopentone drug in case of head injuries and all. Cerebroprotective. That means it decreases cerebral metabolic rate, decreases ICP, etc. Then coming to CV, propofol, it is also cerebroprotective. Etomidate is also cerebroprotective, but this one, it is not cerebroprotective. It is not cerebroprotective, and it increases ICP. It increases ICP and cerebral metabolic rate and all. Then, will thiopentone cause amnesia? Yes, it causes, all of these drugs cause amnesia. Analgesia, thiopentone, propofol, etomidate, they don't have analgesic components, but very important. Ketamine has the only IV induction agent which can use it as an analgesic agent, which can also has the property of analgesia. Then muscle relaxant property, none of them has have. Then coming to cardiovascular system, because it has hypotension with compensatory tachycardia, and propofol cause hypotension and bradycardia. And etomidate is one thing which doesn't have any effect on baroreceptor system or sympathetic system. So that is why it doesn't cause any hypotension, hypertension, nor tachycardia, bradycardia. It is cardiostable drug. So if a drug, if I say this, a drug is cardiostable, so a question came for you in your examination. A 65-year-old gentleman had a previously history of coronary artery disease for which stent has been inserted, and now this patient is posted and his ejection fraction is 38%, and he's posted for hernia surgery. What is your IV induction agent of choice? What is your answer? Come on, guys. Etomidate. See, whatever the question, how lengthier it might be, the clue will always be there in 1 to 2 words. You have to pick it up. The purpose of asking you to take the leaderboards is to pick up that clue in the earliest possible time, how fast you can pick it up so that you can answer the clue. In this question, if you see a 65-year-old gentleman with a history of coronary disease got stent inserted a couple of years back on aspirin and clopidogrel, and he's been planned for an elective hernia surgery now. And what is the IV induction agent of choice in this drug? Rather than asking the question this way, you can ask simply, what is the IV induction agent of choice for cardiac surgeries? In this way also the question can be asked, yes or no. But my dear friends, please remember, in your examinations, the questions are not going to be so straightforward, and this is going to be more clinical. See, more clinical means what? Whatever the knowledge you have, you're going to apply. As simple as that. Yes or no. If I ask you what is the IV induction agent of choice for cardiac surgeries, what will be your answer? Etomidate. So now I'll put it, okay, I'll write it down and I'll tell. And ketamine has effect on sympathetic system, causing stimulates and cause hypertension and tachycardia. Hypertension and tachycardia. Then coming to respiratory system. What is the respiratory system? When coming to respiratory system, if you give partial doses, it causes bronchospasm and laryngospasm. So it is contraindicated in asthma and COPD. Thiopentone is contraindicated in patients with asthma and COPD. And here, propofol blunts the airway reflexes and Etomidate nothing much, and here it preserves the airway reflexes. See, what is the importance of airway reflexes? I told you previously. See, what all some aspiration happens, if airway reflex is there, it prevents, yes or no? So this etomidate, this ketamine preserves the airway reflexes, and the propofol completely blunts. So where can we use this complete blunting of airway reflexes? Where can we take this as an advantage? Fantastic. When you are doing intubation or bronchoscopy or LMA insertion, all these things, propofol is used. Okay. And where can you take this ketamine as an advantage? Asthma patients, bronchodilation, very good. Then very good. In full stomach patients, like when suppose someone had just had lunch and went outside and met with an accident. So in those conditions, if airway reflex has the patient, in those conditions, you can use this. Yes or no? No. What are the uses? Thiopentone can be used for induction, and it has anti-seizure properties. So it can use it for refractory seizures, treatment of refractory seizures, and ECT and narcoanalysis. Coming to propofol, propofol has the property of rapid induction and recovery. So it is used for daycare surgery. Anesthesia for daycare surgeries is also very, very important. So what is meant by daycare surgeries? Heard about daycare surgeries? What are they? See, the patient gets admitted, operated, and discharged on the same day. Okay, we'll discuss about this. Daycare surgeries, ICU sedation, LMA insertion, TIVA, total intravenous anesthesia. Then etomidate. What is the use? Very good. IV induction agent of choice for cardiac surgeries. Then ketamine has this beautiful property of analgesia. So it is the drug of choice. Whenever a burns patient is there, when you want to do dressings and all, use this. Burns dressings, cancer pain, asthma patients because of bronchodilation, COPD patients, in full stomach patients, and those patients with right to left shunt, like tetralogy of Fallot surgeries. There you need to increase the afterload. When we discuss about anesthesia for subspecialties, you can know this is important. Got it? From this table, whatever they want to give in IV induction agents, 90% of the questions will cover from here only. Okay. So the most important thing here I want you to remember is what is this action with CNS, CVS. CNS, it is basically one important point. Which is the odd man out there? When related to CNS, which is the odd man out? Ketamine, it is not cerebroprotective. Then coming to analgesia, which is odd man out? Ketamine, which has analgesic property. Coming to cardiovascular, remember, hypotension and compensatory tachycardia is caused by? Very good. Hypotension and compensatory tachycardia by hypertension. Hypotension and bradycardia? Propofol, very good. And normotension, no increase in blood pressure, no decrease. Etomidate. So hypertension with tachycardia, ketamine. Got it, guys? So you have to be very careful and very, very, very important. Then respiratory system, as I said, like it is contraindicated in asthma and COPD, that is thiopentone, but it is used in asthma and COPD, which is ketamine. Then coming to, these are important questions. What is the IV induction agent of choice for daycare surgeries is an important question. And which is for LMA insertion is an important. TIVA is totally intravenous anesthesia. You are not using inhalation agent. So that is also an important thing. Okay. Now I'll give you a couple of minutes to consolidate this question here itself. Every point regarding thiopentone, propofol, ketamine, etomidate, you should master that. I'll give time here. See here, hypotension is caused by all except halothane, propofol, ketamine, thiopentone. Assume I didn't teach you anything about inhalation agents. Oh, 1 second. Sharing this. Assume you don't know about anything about halothane. Actually, halothane, what it does, we'll discuss here. Halothane, propofol, ketamine, thiopentone, these 4 drugs are given for you. You don't know anything about halothane. You propofol, ketamine, and thiopentone. Among this, you know, propofol cause. What does propofol cause? Hypotension and bradycardia. Thiopentone, hypotension and tachycardia. Ketamine, hypertension and tachycardia. So in these conditions, when you know an answer which is an option which is you correct as very confidently, then don't think about these things. Why you forgot this? I might not have read this. So when you are 100% sure about the answer, don't think about the other options which you are not able to recollect. Understood? Yes or no? So if it's as simple as this question, what is your name? If your name is asked, like 4 options is given, when you are pretty much sure about your name, you won't go back and seeing like, why this name, my name is Sushruth. Sushruth can be Vishruth. You can't keep thinking about that, right? So that is how you have to be very confident about what you are answering. Understood? We will take you in the phase 2 of your training before your this mock examination. We will every day we will tell you way how you can answer the questions. Like when you know all the 4 options, where you have to focus and why, how you can consolidate that question. When you are sure about only 3 options and how you can answer the question. When you know only 2 options and you eliminated 2, and between 2 options you are confused, how you can go. When you know only 1 option and you don't know about 3 options, still how you can go to the question, how you can read the examiner mind, and how you can answer the question. This is all you will be taught, because when it comes to the examination per se, it's not only just knowing about the concepts. Knowing and answering the questions, knowing the concept and answering them in the right way is very important. Yes or no? After knowing all this concept, if it won't be reproduced into your examination, there's no use in that. So first, like we will train you in that fashion. Okay. Then, yeah, you will have 1 more minute to consolidate this. And then coming to the next question. Minimum alveolar concentration of an inhaled anesthetic is a marker of potency, efficacy, elimination, duration. How many for potency? Lift your hands. How many for efficacy? Elimination? Distribution? What about others? Like few people answered efficacy, potency, and rest all you take whatever you want, like we don't answer. See, this is very, very, very important concept in anesthesia. See, assume now you are sitting, and when you see this, now all of you had lunch. Yes or no? So what did you have for lunch? Chapati, biryani, curd rice. Okay. So now you had lunch and you came and sit here. This group, assume these are 3 groups. A group, all of you ate chapati. B, all of you ate biryani. C, you ate curd rice. And I started taking a class in anesthetic agents, how nicely the anesthetic agents. And after some time, I noticed that like 50% of the people are also got anesthetized, sedated, hypnotized. So among this, assume that all of you had eaten uniformly, like 300 grams. I had given 300 grams of chapati to this group, 300 grams of biryani to this group, 300 grams of curd rice to this group. Among this, who has the highest propensity to sleep? Curd rice. Okay. After that, biryani and then chapati. So when I had given an equal amount of the food, when with the same thing, curd rice people are more than 50% of the people are getting anesthetized or like getting sleep there. And when compared with those chapati, which is the most potent sedative food here? Curd rice. She's so proud. Yes, our curd rice. Okay. See, that's how. Similarly, just take an anesthesia. We are breathing in. Normally, what are we breathing now? What are we breathing now? Oxygen. How much percentage? 21%. In addition to this, we'll breathe 79% nitrogen. Under anesthesia, we won't give nitrogen, we'll give nitrous oxide, which also can take care of analgesia. So oxygen will give up to 40 to 50%. So among the 100% what we breathe in, just try to understand this, guys. Among the 100% is what we breathe in like 40 to 50% oxygen, and rest is nitrous oxide and an inhalational agent like isoflurane or sevoflurane or desflurane, whatever is there, you keep adding to that. So this is the one, this isoflurane, sevoflurane, desflurane or halothane is the inhalation agent which makes the patient anesthetized and sleep. Okay. Among this, which is more potent? So assume isoflurane in the 100% what we are breathing, I had given isoflurane 1% among 100%. Sevoflurane I had given 2%. Desflurane I had given 6% among the 100%. Still, I get the same effect. Same number of people will get anesthetized. So which is more potent here? Come on, guys. Isoflurane. So similarly, if I say among the 100%, if isoflurane is getting the same effect of 1%, that's desflurane as 6%. So which is more potent? Isoflurane. So similarly, this MAC or minimum alveolar concentration is nothing but the concentration of an inhalational agent at which 50% of the patients do not respond to surgical stimulus. When you give surgical stimulus, the patient should not respond or move. So that is what our immobility should be there. That is what it is, minimum alveolar concentration. So that is indicator of minimum alveolar concentration is indicator of potency. How many of you watch cricket? How many of you watch cricket? 1, 2, 3, 4, 5, 6, 7, 8. What do you people do? I'm seriously curious. You don't watch cricket? Trojan shoulders? Who is your favorite cricketer? Dhoni. Who answered that? Who answered Dhoni? What's your name? Siddharth. Now, few questions on Dhoni. What is the full name of Dhoni? Very good. Mahendra Singh Dhoni. For you. Okay. Mahendra Singh Dhoni. What is his nickname? Mahi. What is the 3-letter nickname? MHD? Yes. So now we will mix up this thing actually. Mahi HD. What is the short, Siddharth? What is the short? Who told that? 2011 World Cup Finals. What is the date? Last year. World Cup Finals in which year? 2011. Date. Siddharth, Dhoni fan you are. April 2nd. What is as iconic as this shot? Who gave the commentary then? Ravi Shastri. Harsha Bogle, who told? Watch or do anything with the passion, man. It's the commentary of Ravi Shastri. Can anyone remember what is Ravi Shastri's commentary there? Dhoni finishes off in style and It's a magnificent strike into the crowd. India left the World Cup after 28 years, and it's the party started in the dressing room. Siddharth, come on. Yes, and it's an Indian captain who has been absolutely magnificent in the night of the final. It's 21 seconds. You people are saying cricket fans, and you are saying Dhoni fan, and India. He brought the World Cup, and you won't remember this. Okay, now for us, even if you forget what Ravi Shastri commentary is, you can't remember, you can't forget this Mahi HD. Sit down, please. Mahi HD. So in this Mahi HD, Mahi is Mahi, as you told, HD, Mahi HD. So before we come to Mahi HD, we'll write down few points. MAC is nothing but the concentration. MAC is minimum alveolar concentration. Minimum alveolar concentration. It is the concentration at which 50% patient do not move to surgical stimulus. The unit of MAC is percentage. It's an indicator of potency. Mayer-Overton law says like potency is directly proportional to lipid solubility. And most potent is methoxyflurane. Least potent is nitrous oxide. Methoxyflurane, the MAC is 0.16. So among 100%, if you give methoxyflurane, it has the same effect as halothane 0.79, isoflurane 1, sevoflurane 2, desflurane 6, xenon 71, nitrous oxide 104. And methoxyflurane M 0.16, 0.79, 1, 2, 6. So when you go from M to D, what is happening? MAC value is increasing. When MAC value is increasing, potency is decreasing. Very, very, very important. If they give ascending descending sequence also, you should not forget this. Got it, guys? Yes. I'll give you 30 seconds to consolidate this concept before we go to the next question. So the answer is potency. $15 seconds more. Good. Okay. Then in anesthesia, fitting of wrong gas cylinder to the anesthesia machine can be prevented by pin index. Very good. Pin index safety system. So yoke assembly is also high pressure system, but you won't do that. Bodax seal, gas analyzer, these are all components of the yoke system. See here. Pin index, as discussed, pin index safety system. It prevents the wrong attachment of cylinder to anesthesia machine. Where is pin present? Page number 19. Where is pin present? Machine or cylinder? Machine. Hole is present in the cylinder valve. So based on that, there will be pin index where air, there will be two numbers of pin index for each except the internox where the single thing. So remember, very important, pin is present on anesthesia machine. Hole is present on the cylinder valve. Pin index of oxygen is 2.5, nitrous oxide is 3.5, air is 1.5, pin index of entonox is 7. So this pin index will be ineffective if wrong gas is filled in the cylinder. And in conditions of damaged yoke pins. And as I told, this is very important table. All of the following exists in physical form as gas except nitrous oxide, carbon dioxide, and cyclopropane, which exists in liquid form. Pin index of air is 1.5, oxygen is 2.5, nitrous oxide is 3.5, carbon dioxide 1.626, cyclopropane 3.6, entonox 7. Pressure, air and oxygen approximately 2000 psi, nitrous oxide, carbon dioxide approximately. Answer? Very good. 760 psi, cyclopropane around 70. What colors of the cylinder? Very important. Come on, keep telling us. Air. Very good. Gray body with white shoulder. Oxygen. Black body with white shoulder. In the examination, don't get confused if they ask black shoulder with white body. Read the question, options, and then mark it. The questions which you are 100% confident of, remember guys, a question which you read in the class, which you listened, you read, you know, you revised, those questions you should not make a mistake in the examination. As simple as that. Okay. With white shoulder. Nitrous oxide is blue in color. Carbon dioxide gray. Cyclopropane orange. Entonox, very good. Blue body with white shoulder. Helium, brown. Okay, this is about pin index. Very important. 30 seconds to consolidate this table. Pin index is very important. Fifteen seconds more. Okay, then majority of you have made a mistake in this. That's absolutely fine. See, as I keep saying, it doesn't matter to me how many questions you got it correct, but a mistake has to be made only once. Mistake should not be repeated. That's as simple as that. Like if you won't repeat the mistake, you are halfway through. A patient in ICU is weaned from ventilator, the mode least used for this purpose. What do you understand by this? A patient, you kept him on a ventilator in ICU. Okay, he's improving, he's recovering. You are slowly weaning. What is weaning means? Bringing out from the ventilator. You are bringing out, which is the mode least used for this purpose. So here you have to know about what is the full forms. ASB is assist spontaneous breathing. I will go to that chapter. CPAP means continuous positive airway pressure. SIMV means anyone? Synchronized intermittent mandatory ventilation. CMV is controlled mechanical ventilation. So we'll go to this chapter. Go to page number. Come to page number 175. Come to page number 175. Again, see this. This mechanical ventilation chapter is, there are like 5 competency codes related to that, 7.1 to 7.5. Both the knowledge and skill components in being assessed. It's vertically integrated with the physiology and horizontally integrated with the general medicine. This concept and this chapter is designed based on this competency codes. Okay. If you see this, the questions asked in last 5 years, 6 important topics. If you see, can you see the weaning modes? Yes. So weaning modes is important. Weaning means nothing but the bringing out of the patient from the ventilator. The modes of ventilation, there are like something called controlled mechanical ventilation. Medicine itself is half English. Controlled mechanical ventilation. You are controlling mechanically the ventilation of the patient. Patient is not breathing anything by himself. He's completely under the muscle relaxant effect. There are 2 types of respiration. What we are breathing in now, that is spontaneous breathing. Yes or no? We are breathing spontaneously. Controlled breathing means the patient is not able to breathe and the muscle relaxant is given and the anesthesiologist is controlling the patient's breath through the machine. So controlled mechanical ventilation, intermittent mandatory ventilation, the patient can breathe in between. It's synchronized intermittent mandatory ventilation. See what happens in IMV, intermittent mandatory ventilation is the ventilator, suppose here in controlled mechanical ventilation, you set it, no need 500 ml per minute, 500 ml per breath, 12 breaths. So this ventilator will deliver for this patient 12 breaths per minute. Each breath, how much ml? 500 ml. That you set as volume control. So every breath it is delivering 500 ml. Then intermittent mandatory, here there's no spontaneous breathing, nothing. Patient is completely sedated, paralyzed. In intermittent mandatory ventilation, what it does is the ventilator still gives the 12 breaths and the patient also can breathe in between. But he's not still capable of generating 500 ml. He can generate up to probably like 10 ml, 50 ml, 20 ml, and his breaths are like 1 ml, 1 breath, 2 breaths. Whatever he generates, intermittent, he can breathe in between. Then what is the difference between synchronized intermittent mandatory ventilation and intermittent? In synchronized intermittent mandatory and IMV, if you see this, IMV, just assume the ventilator is giving the breath. This 500 ml ventilator is giving. And patient at the time started exhaling. Vice versa. The patient, the ventilator is bringing out the expiring. At the same time, the patient starts breathing. So what happens? There will be breath stacking. And it may cause barotrauma. So they developed another method called synchronized intermittent mandatory ventilation. What does it? There is a sync between the patient breath and ventilator breath. Okay, that means here the patient can breathe spontaneously. Suppose the ventilator is giving the breath and the patient also breathes. So what the machine does is it stops there and helps assisting the patient's breath. Understood? Then pressure support ventilation. Here in this pressure support ventilation, I mean, everyone please focus. Pressure support ventilation, what it does is patient is not able to generate completely this 300 ml, 500 ml. He is able to generate like 200 ml, 250 ml, whatever is there out of this 500 ml. So what this ventilator does is it is not giving any breaths. Patient himself is breathing all the 12 breaths spontaneously, but is still not able to. You need like 500 ml breaths as 12 you need per minute, but he's not in a position to, he's able to breathe this 12 breaths, but he's delivering only up to 300, for example. So this ventilator, what it does is it, giving the pressure, it supports that from this 300 to reach 500, it supports. This is called as pressure support ventilation. Understood? Yes or no? So this IMV, SIMV, pressure support, CPAP. CPAP is continuous positive airway pressure, which you keep it at the level of upper airway. These are weaning modes of ventilation. In your examination, see, I can explain in length about this, but for you, for your examination, I want you to remember this one point, right? What are the modes of weaning? Weaning modes of ventilation are, even IMV we are not using nowadays. So remember at least 3 things: SIMV, pressure support ventilation, PSV, and CPAP, continuous positive airway pressure. SIMV, PSV, pressure support ventilation, and CPAP, continuous positive airway pressure. SIMV is, okay, I'll write down the full form so that it will be easier for you. SIMV, synchronized intermittent mandatory ventilation. PSV, pressure support ventilation. CPAP, continuous positive airway pressure. Continuous positive airway pressure. Okay, this weaning modes of ventilation question, please don't make any mistake in the examination. It's very simple and straightforward. Okay, then coming to the next question. So now tell me, what is the answer in this? Answer? CMV, controlled mechanical ventilation, you can never use for weaning because the patient is completely under the muscle relaxant effect and complete sedation. Now you may got a doubt, what is ASB? Even if full forms is there in the examination, they say assist spontaneous breathing. If they say, if full form is given, assist spontaneous breathing, if it is given, the name itself says the patient is having spontaneous breath. It's a medium. Sorry? No. They can give any options like ASB. ASB we are not using now so commonly. Even in those conditions, you have to accept, you have to understand what is this. Okay. Then coming to next question. Which is the most cardiotoxic local anesthetic? Bupivacaine, lignocaine, lidocaine, or ropivacaine? Bupivacaine, very good. So bupivacaine again an important topic. If you see in the INSET, last 3 papers, 2 times there was a question on bupivacaine cardiotoxicity. That is why I emphasize this question here. So what is the peculiarity? See, bupivacaine, where do you use? Have you gone to operation theaters? Yes. Where do you have you seen spinal anesthesia being administered? Spinal, yes. So what is the drug used? What is the drug used? Bupivacaine. Bupivacaine, it is 0.5% bupivacaine heavy or hyperbaric. So what you do is, the drug what you give in spinal anesthesia, it is heavy or hyperbaric. That means dextrose is added to make it more heavier than CSF. Why do you use CSF? Why do you make it heavier? Because when you give the drug into the CSF, CSF will be flowing from, will be circulating from to the level of ventricles, right? If this drug, whatever you give, if it goes and acts on the brain, is there any use of that? And also it may cause high spinal and total spinal, like the drug is circulating. So to prevent that, we need the spinal, whatever give the drug effect to be fixated. So to make the drug more heavier than CSF, you make it hyperbaric by addition of dextrose. So in this, bupivacaine is very important. But at the same time, bupivacaine, why it has become so popular as spinal anesthetic, it has a differential blockade properties and all, which we will discuss, but it has highest cardiotoxicity. So here we will again go back and write down important points about this. This is bupivacaine, which is long acting, and it is 8 times more potent than lignocaine. Most commonly, this is in from page number 124. Most commonly used drug for spinal anesthesia and labral analgesia. Its characteristic has differential blockade. Differential blockade. What is this? In low dose, only sensory component is involved, and in high dose, both sensory and motor components will be involved. And this is the most cardiotoxic drug, so that is why it is contraindicated in those with IVRA, intravenous regional anesthesia, which we'll discuss. Then I want you to remember this: arrhythmias. The most common arrhythmias are ventricular arrhythmias, which you treat by amiodarone, procainamide, bretylium. And this is not so important. The most important thing is this one. Very, 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 very important. The bupivacaine-induced cardiotoxicity is treated by intralipid formulation or lipid emulsion. The drug is usually, they say, 4 to 20% intralipid formulation or lipid emulsion. Lipid emulsion. And remember, the cardiac arrest which occurs post bupivacaine toxicity. You have given bupivacaine, and if cardiotoxicity occurs, it is very, very, very difficult to revive. Cardiac arrest is poor prognosis. Cardiac arrest occurring due to bupivacaine toxicity, so poor prognosis and very, very difficult to revive. What happened? Any doubt? Any doubt? Sorry? Am I audible? 4 to 20% intralipid formulation or lipid emulsion is poor prognosis and very difficult to revive. Very difficult to revive. Sorry? IVRA is intravenous regional anesthesia, which we'll discuss in the next chapter. IVRA is intravenous regional anesthesia. So this is very important. Most cardiotoxic drug is very important. And the formulations, 0.5% is used for peripheral nerve blocks. 0.5% heavy is used for spinal anesthesia. 0.125 to 0.5% is used for epidural. 0.0675 to 0.25% used for labor analgesia. Labor analgesia means anyone? During pregnancy, you use in a much lower concentrations, the sensations will be there, but the motor component, the patient can't feel the pain, but still contractions can be there. And remember, all this cardiotoxicity, neurotoxicity, all this occurs when you give the drug more than the maximum safe dose. Okay, more than the maximum safe dose. Maximum safe dose you can give in milligrams per kg without adrenaline is 2.5 milligrams per kg, with adrenaline 3 mg per kg. Duration of action 2 to 3 hours and 3 to 5 hours with adrenaline. Done? Okay. Then coming to the next question. So what is the answer? Most cardiotoxic local anesthetic? Okay. Then Mendelssohn syndrome is due to gastric dilatation, wrong intubation, tracheal inflammation secondary to intubation, chemical pneumonitis following aspiration. Come on, guys. Chemical pneumonitis following aspiration. So Mendelssohn syndrome is nothing but chemical pneumonitis or aspiration pneumonitis in pregnancy. Seen in pregnant. pH how much? Very good, less than 2.5. Volume? More than 25 ml. So it is basically if aspiration occurs. This is page number 15. At the same time, also remember this fasting guidelines. See this Mendelssohn syndrome comes under the fasting guidelines, and because in relation to that, what do you if you don't fast, like what exactly happens? And here, can you see this code? 3.5 is based on skill. It's integrated horizontally with both the medicine and surgery. Come on, now fill up this. Adults, what are the clear fluids? How many? 2 hours, all in hours. Semi-solids, solids light meal, 6 hours. Solids fatty meal, 8 hours. Then children, clear fluids, 2, or if option has 1, go for 1. Breast milk, 4 hours. Solids light meal, 6 hours. Solids fatty meal, 8 hours. Formula milk, 6 hours. Got it? Okay. You have 15 seconds to consolidate this question. Next question. In spinal anesthesia, the drug is deposited between. In spinal anesthesia, the drug is deposited between pia and arachnoid, dura and arachnoid, between pia and dura, outside the dura. Anyone? Pia and arachnoid. So what are the structures that appears? See here. This is very, very important. The structures we encountered during lumbar puncture from back to front: skin, subcutaneous tissue, oh sorry, 136. Skin, subcutaneous tissue, supraspinous ligament, interspinous ligament, ligamentum flavum, dura mater, and arachnoid membrane. Skin, subcutaneous tissue, these are the structures pierced. Like even they may ask you in back to front, what is the sequence? All the which is the correct sequence: skin, subcutaneous tissue, followed by supraspinous ligament, interspinous ligament, ligamentum flavum, dura mater, and arachnoid membrane. So the drug will be deposited after the arachnoid membrane. That is, here the pia will be there. So between this, the drug is deposited. Done? Noted? Then next question. Intravenous anesthetic induction agent used in daycare surgeries. We discussed propofol, very good. When they give the question as daycare surgery or a person who is called a street fit, that means he can walk normally, street fit person, all this, the answer will be propofol. So propofol, where all you can use propofol? Daycare surgery, ICU sedation, LMA insertion, TIV, that is total intravenous anesthesia. You can give that. Ketamine, where do you use? Just to consolidate. Burns dressings, very good. Cancer pain, neuropathic pain, very good. Then asthma and COPD patients. Right to left shunts. Full stomach patients, very good. Anything else you can think of? See, this increases heart rate and blood pressure. Yes or no? So can we use this in a patient who is in shock? Very good. Shock. Then coming to etomidate. Etomidate, where do you use? Cardiac surgeries. Very good. Thiopentone, it is used for induction, refractory seizures, narcoanalysis, even in ECT. Okay, this is important. Got it? And here again go to this go to this page number 72. See here, propofol is the IV induction agent of choice. This table is very important. Propofol is IV induction agent of choice for daycare surgery because the patient has fast induction and recovery. ICU sedation because the patient has no neurological side effects. LMA insertion or endoscopy because it blunts the airway reflexes. TIVA or total intravenous anesthesia is given in the presence of propofol plus fentanyl group of drugs. Propofol and fentanyl group of drugs. Propofol and fentanyl group of drugs. And it is used in the treatment of the patients, as we discussed, right? Malignant hyperthermia. Patient has history of malignant hyperthermia. In that patient, if you want to administer anesthesia, you use propofol. And porphyrias, we'll discuss. Thiopentone is contraindicated in porphyrias, particularly acute intermittent and variegate porphyrias, which propofol can comfortably use. This is very, very, very important. Then coming to the next dose, this was a question asked in 2021, and I said dose ratio of adrenaline to be used with lignocaine: 1:200, 1:2000, 1:20,000, 1:2 lakh. 1:2 lakh. Very, very important. See, this is basically what are you using? Lignocaine in the presence of adrenaline. What is adrenaline? Vasoconstrictor. Why do you want to use this? We'll go to this. See this. The absorption of the body depends on, see, when you're given a local anesthetic, just assume 120. So now the local anesthetic drug, you take it two people of same height, same weight. In fact, like let's take same name like Balaji. And for one person, you have given on the face 10 ml of the drug, and another person you have given same 10 ml over the leg. So after this, after 15 minutes, you see how much amount of drug is there in the plasma, that is in the blood. Usually when you are giving a local anesthetic, what is your target? To give into the blood or to stay there for more time? Stay there. The name local anesthetic itself says it has to stay. So, but when you give this drug, wherever the vascularity is more, it gets absorbed fast. Yes or no? So, but our target is to make the drug stay there for more time. So what you do is you use this along with the vasoconstrictor like adrenaline or phenylephrine. When you use this, the absorption decreases, the systemic absorption decreases, and the drug stays there for more time. Understood? So this addition of vasoconstrictor here, because more vascularity leads to faster absorption, this addition of vasoconstrictor, it decreases the local blood flow, decrease the sympathetic systemic absorption, and increase the duration of action. And adrenaline is administered in 1:2 lakh concentration, and phenylephrine in 1:20,000. But remember, local anesthetic with vasoconstrictor is contraindicated. Anyone? No, in those conditions, in which part of the body? Wherever there are end arteries, like ear lobules, nose, fingertips, penile arteries and all. Please write down. Penile arteries, ear lobule, pinna, fingertip, and penile arteries. Done, noted? Then, next question. You have to tell this, guys. Anesthetic which increases intracranial tension. Fantastic. Ketamine is the answer, like which increases ICP. So we discussed the propofol is cerebroprotective, decreases, and etomidate is also that. Either you don't know, but you know that ketamine is not cerebroprotective, it increases ICP. So go ahead and straightforward answer this. So when you know confidently something, don't dwell into the other things too deep. Okay, that's one fundamental aspect in answering the multiple choice question examinations. So then go to page number probably. Go to page number 74. When I say the word ketamine, what will you remember? Fantastic, dissociative anesthesia. See, ketamine, it is a potent analgesic. It increases cerebral blood flow, increases ICP, cerebral metabolic rate, etc. And it causes something called dissociative anesthesia. That is dissociation of thalamus from the limbocortical system. It may cause side effects like hallucinations and emergency reactions. You prevent by administering benzodiazepines. Prevention is by benzodiazepines. Decreased incidence is seen in old age. Now, CVS, it causes sympathetic stimulation, causing increase in heart rate and blood pressure. So it increases myocardial oxygen demand. So when it increases myocardial oxygen demand, In what are the cases where it is contraindicated? Very good, fantastic. When the patient has MI, when the patient has hypertension, aortic aneurysms, all these things. So it is contraindicated in those patients with MI, aortic aneurysm, then hypertension. Now tell me, I'm taking this as an advantage of heart rate and blood pressure. What is the IV induction agent of this ketamine can be used as IV induction agent of choice in patients of shock? Very good. Shock. IV induction agent of choice in shock. Then respiratory system, it causes minimal respiratory depression and it maintains the upper airway reflexes. So it is used for induction in full stomach patients. And it is a potent bronchodilator. So that is why it is the drug of choice in answer. Very good. Asthma and COPD. Asthma and COPD. Then, now tell me, what are the uses you know about ketamine? Very good. You know, Burns dressings. Very good. Burns dressings. Cancer pain. Neuropathic pain. Phantom limb pain. Patient with shock, asthma, COPD, full stomach patients. Right, very good. Right to left shunt. Right to left shunt of tetralogy of Fallot. Okay, and it is contraindicated in, come on guys, contraindicated in MI, very good. Hypertension, good. Aortic aneurysm, very good. Very good. Neurosurgeries, okay, please write down. Contraindicated in those conditions where there is increase in ICP or in those with head injuries, those with space occupying lesions. Epilepsy, ischemic heart disease, aortic aneurysm, hypertensive, glaucoma, and schizophrenia. Glaucoma because it increases IOP. Okay, then see, these are all very important. This IV drugs, this is a very important based on this NMC competency code. Then come to the next question. Intravenous anesthetic agent causing suppression of steroid synthesis. Very good, fantastic. Etomidate. So here, remember about etomidate, few important points. The side effects of etomidate is very important. So etomidate, cerebroprotective drug. It is the most cardiostable IV agent we discussed. No effect on sympathetic system and baroreceptor system. And it is a drug of choice in cardiac surgeries. And endocrine, it causes adrenocortical suppression by inhibiting 11 beta hydroxylase. That is in high doses. In high doses. What are the uses of this etomidate? It is used for induction or start of anesthesia, induction of anesthesia, cardiac surgeries like CABG, valvular surgeries, thoracic surgeries, aortic aneurysm surgeries, PTCA, that is coronary angiogram, hypertensive patients, in hypertensive patients. What are the side effects? Remember, it causes maximum nausea and vomiting, pain, thrombophlebitis, hiccups, myoclonus, vitamin C deficiency, adrenocortical suppression. Adrenocortical suppression. So this adrenocortical suppression steroid synthesis, which happens in high doses, is caused due to which drug? Etomidate. Okay. Now we'll break for 15 minutes and then again we'll resume at 4:15. Okay. Sorry.